All right, so we're live. So I'm on my Facebook. I'm also on my work YouTube channel and my regular Twitter, streaming over these three. For this one, it's about my work. I want to go through a really interesting case that I had that was very enjoyable to work on this patient. Really did some amazing changes to improve the distribution of ventilation using the PulmoVista 500 on this patient. The patient was here for neurological issues, encephalitis, acute kidney injury. So it's still quite mysterious. There's more investigation that's needed, but the patient required intubation because of the decreased level of consciousness. So this was the first time that I had the patient. The patient was on a PC-PSV. So they had him on a rate of 20, PEEP of 10, delta P of 15. So the PIP was set at 25. And so it's kind of like ACPC, but flow cycled, the mode. And I'll show you. So basically, I put the PulmoVista on. It's a electrical impedance tomography. It's a belt with 16 electrodes. I'll show you one of my PowerPoint presentations that I show kind of an introduction into what it is before we get into the case study. So let's jump into this right now. I'm hoping to do more and more live streams related to respiratory therapy. And I hope that I'll be able to get more healthcare professionals, residents, physicians as well to have conversations about PulmoVista as well as APRV. I use APRV in the ICU on some patients. It works very, very well for certain individual patients. What we do is everything is decided if we're going to transition from a conventional mode to APRV. I won't say every time, but most of the time, we're going to do this guided under electrical impedance tomography so that we can see regional distribution of ventilation as well as regional compliance changes. We can see where there's overdistension, what percentage, compliance loss, compliance gains. This technology is, in my opinion, the future of our profession as respiratory therapists. It has completely changed the way I kind of imagined what was going on in the lung. And I am totally convinced that this will be just, a major part of the future. And it really propels us into clinical status. The stuff that I'm able to pull out the information, everything is open. It's like we have, when we arrive at the patient bedside, usually with a ventilator, we're looking at the screen. We have all those numerical values. We have those waveforms and stuff like that. But to a certain extent, it's like, the top of the iceberg. Okay, we have a certain amount of information. We have good science about, that information to make it as protective as possible. But we have no idea, the iceberg, the size of it underneath the water. And it's the same thing. The PulmoVista gives us eyes inside the lung. We see that tidal volume that we see on the vent, how it's distributed, okay, in a dynamic fashion. I've seen some configurations of other electrical impedance tomographies. The Draeger is, in my opinion, the best configuration for APRV on the Draeger, and it's as well for a electrical impedance tomography device. The PulmoVista 500 is the Corvette, is the Ferrari of this technology, in my opinion. And I'm hearing rumors that there will be an addition to that. So if you already have the PulmoVista, I'm not a Draeger rep, so maybe I'm starting a rumor, but I've been hearing that there will be a pod that you can add, which you can have transesophageal measuring, so that you can also have that pleural pressure. So let's just go for people who have never heard about electrical impedance tomography, just give a kind of introduction to the PulmoVista 500. Also going to invite for healthcare professionals. Let me see if I can post here. All right, so the StreamYard link should be there. If you're interested in coming up, questions about APRV, questions about PulmoVista, you can come up right now, and this can be interactive. Ideally, this is what I want. I want people coming on. I want panels. I want discussions. I don't really see any live streams for rest therapists or mechanical ventilation stuff, where hopefully, you know, we can start getting a good group, and this could be, you know, a place of dialogue as well. And we can share case studies. Let's say you're here listening and you're a rest therapist. Well, take out your video and, you know, make a case study and come and present it here. All right, start from the beginning. I'm just going to play my video here, just to make sure I know what I'm looking at here. Bear with me, guys, for a second. Start reading that there. Okay, so the PulmoVista 500 is an electrical impedance tomography. This is a non-invasive monitor that helps you visualize the distribution of ventilation within the lung. It gives dynamic images in real time, and all of this is done directly at the patient's bedside. Unlike, for example, CT scan that uses radiation, you know, the RT brings the patient down to CT scan. RT wants to see that chest CT, wants to see if there's any, you know, dorsal issues. But now, as far as the RT, who is concerned about that CT scan, looking at the aeration, the consolidations, you know, the lung collapse, you don't have to have a CT scan. And if the intensivist is sending a patient just for a CT scan, concerned about the ventilation, you don't have to. You can tell them, look, we can put on this non-invasive monitor, no radiation, and we can see right away. So here's just an image of the belt. It has, just a minute. So yeah, it has 16 electrodes, and then after it has like a control that you snap on right there. And there's a reference ECG dot that you put it. And this is another way of looking at it. So it goes around the chest, and these here will be hooked up onto the actual EIT machine. So the electrical impedance tomography, it sends a low frequency current, and that current crosses the lung. The electrodes measure the impedance changes inside the lung during the respiratory cycle, inspiration, expiration. Right away, get it in your head that impedance is equal to volume, okay? So increased impedance is equal to increased volume, and the opposite, decreased impedance, there's a decrease in volume. Impedance is another way of saying resistance. So when on inspiration, there's more air, and that signal has to pass through that air, and that causes more resistance than when there's no air. It can also measure negative impedance values such as fluid. So sometimes it will pick up and it will show us purple in the center. That's just picking up the liquid, the fluid in the heart. And if you have a significant fluid accumulation, like a pleural effusion, that as well can show up. The placement is about 2 inches below the armpit. They say fourth to sixth intercostal space. That's quite hard, right? To try and figure that out in a ICU patient with all, lines and everything on them. But roughly put it. So what you usually would do is you put the patient in a sitting position, all right, like you would do if you're going to advance the patient for an x-ray, to slide the x-ray slide. So you have, people help you supporting the head, advance the patient, slide it down. And then prior to sliding it down, I usually get it under the neck, and I kind of put those two, these two dangly things over here. I usually put them like under the armpit because that's where they'll end up being. So then it's slid behind the neck, it's under the armpit, and then all I have to do is advance it, lower it. There's a little notch to put it on the spine, and you just want to make sure that when you close it, 1 and 16 are kind of not like they're on equal side of the sternum, okay? Or else you're going to have like a curved image. The normal distribution of ventilation, first of all, we're looking at a caudal to cranial view, just like a CT scan. So this ain't like a AP X-ray. This is caudal to cranial. You're at the foot, and you're looking at the patient towards the head. The top here is, let me just get a pointer option. The top here is the sternum. This would be the chest. This would be the right lung. This would be the left lung here. So you have the outward template, just to let you understand where you are as a reminder. So this would be the spine, the sternum. So this is you're gazing in caudal to cranial. The normal distribution of ventilation is written from ventral to dorsal, the 8 to 15 at the ventral and dorsal, and the mid-ventral and dorsal is 35 to 40%. That's the normal distribution of ventilation. The distribution of ventilation will show up in blue. So when you have blue, that's where the aeration is. There will always be within the blue a certain amount of white. The white helps to show where a larger portion of, or the majority, a large portion of the tidal volume is going, where you see this white appearance. So you want the white to be kind of like well blended in, well distributed within the blue. Sometimes you'll have the blue, and then you'll have this area where it's like the white is just like a circle. And right away that tells the clinician there's a distribution, but that area where that white is appearing at the end of inspiration, there's more, the alveoli have to deal with more of the tidal volume. So there's a non-homogeneity, or it's not well distributed, and your eye catches that right away. As mentioned before, the majority of us, what we have is a certain amount of information when we get to the patient's bedside. And I like to use this analogy, or it's when we get to the bedside, okay, we don't know everything about the lung, right? We don't know what's going inside the lung. We don't know what's around the lung. We don't have the pleural pressure. If we don't have so we arrive at the ventilator, and we have, like I said, the tidal volume, minute ventilation, we have compliance, we have flow, we have all of these pressures. So we have numerical values with good science over the last, 2 decades, with the lower tidal volumes, higher PEEPs, improved mortality, but we still have a long way to go. The mortality for ARDS is still unacceptably high. So what we're saying here is that the PulmoVista, okay, when you arrive at the vent, you have global measurements like plateau, compliance, delta P drive pressures, and these can be found here. But the PulmoVista 500 gives us regional measurements. So now you can see not only on top of the water, you can see under the water. You can see what's happening under the water. And this is because you can get end inspiratory lung volume. So this would be for recruitment at the end of inspiration. Okay. Have we recruited that area? That end of inspiration is opening up. End expiratory lung volumes. We can adjust PEEPs. And, you can increase the PEEP from 6 to 8. You can just leave it there, put the 6 as a reference, wait a while, and then you can see if that adjustment from 6 to 8 has recruited end expiratory lung volume. Now, these measurements will be end expiratory lung impedance, end expiratory lung impedance, but impedance and volumes, again, are the same. So they're easily translated from impedance values to tidal volume values. Regional distribution of ventilation and changes in regional compliance. So because it's able to measure not just distribution of ventilation, but regional compliance, then we're able, this technology is able to do optimal PEEP studies. I use APRV, like I said, in select patients in our ICU with very, very good results. So we also can use the customized analysis on the PulmoVista 500. And what we'll do is we'll set our P high at different levels. Often, if we're in a conventional mode, we'll transition whatever the plateau was in conventional mode. I'll kind of start with a P high. It's a good starting point. Or if I'm in pressure control, the peak inspiratory pressure is a good starting point. You can do that. And then after, you can do some titrating up and some titrating down. And then after, you press custom analysis, and the PulmoVista will give you the P high setting for your APRV that it puts the lung in the most compliant region. Yeah, that's quite unique. So obviously this is a snapshot of the main screen. You have the dynamic image. So this will actually be, you'll see it, in inspiration, expiration, moving. This is the tidal volume. I'm going to have to take another snapshot because actually when you press the reference up here, your reference shows up there. And then from there, it's locked there unless you change the reference, and everything else is compared to that, because you're going to be able to scroll down this time axis with all the stuff that you've been doing over the last 5 minutes, hour, 3 hours, whole shift. It's all there, and you don't have to remember. If you're not connected with a Draeger product, then you can still use this, but you're gonna have to mark events. You're gonna have to have a paper just to remember A, B, C. It's not gonna give numerical value. So you just have to remember and make sure to mark your events. Again, these are the impedance values: inspiration, expiration, inspiration, expiration. These will match very closely to the curves on your volume. This is the global volume, and here we have regions of interest. So I have this divided in 4 layers, and we could put this in quadrants, to see like right upper quadrant, right lower quadrant, left upper, left lower, or we can put it as well in layers. Often we are concerned about optimizing the mid-dorsal to dorsal regions, the gravity-dependent regions that often are the ones that will be most at risk of shutting and closing. So we see over here that the tidal volume is, I'm just gonna have to take a better snapshot. Usually the volume shows up here. And let's say if this was 500, the tidal volume, then I could multiply 500 times 0.08, because this is a percentage. And I could say that, well, I don't know what 500 times 0.08 is, 50, 48, a little less than 50. So 50 mLs of the 500 is going here. And then you can multiply your 500 tidal volume that I'm pretending it's 500 times 0.41. And again, you can translate these impedance, numerical impedance, values or percentages into actual tidal volume. Okay, over here, this is the end inspiration. Again, here's your reference. This is an example of somebody that had the PEEP at 5 and we went all the way up to 14. And we could see here when the PEEP was at 5 that there was dorsal collapse. We can see that only 3% over here of the tidal volume. So this is PEEP of 5. We have it, we can see over here the PEEP, so we're not lost. Remember I was telling you it shows you everything if you're connected to the Draeger. And here we went up to PEEP of 14 and we were able to recruit. With this, we have a color-coded representation of what's happening here. It's comparing the 5 to the 14 PEEP. This was closed, now it's opened. When that means that blue means that compared to here, there's more aeration. So that's why it's blue, okay? And because this opened, that means that when this opened, some of this volume that was here with this intense white, it was trapped here. Well, when it opened the dorsal, not only did you gain in the fourth layer, the dorsal region, you redistributed. You lost some of this volume because now there was room down here. So here's the redistribution from the more ventral and mid-ventral areas to be distributed to the dorsal region, indicating recruitment. There's a lot more that we can pull out here. I'm doing a quick, quick little presentation because I'd like to show you the case that I did, and I don't want to be too long. Yeah, under here, this represents the FRC. Here, we could see when we went up from 5 up to 14. And then after we start going down, so we actually go down to 12, 10, 8, 6, and you can see how this stays straight, the impedance value? It means that the recruitment is maintaining. They dropped to 12. So obviously you drop 14, 12, it's normal to go down, but it's not trending downwards. It's holding itself. But the minute you start going anything below 10-ish, you really see a steep decline here, meaning that if I would to reset it at 8 or anywhere from below 10, I'd likely be losing all of this FRC that I had recruited, and I'm going to lose the dorsal region. We can actually calculate our functional residual capacity. Same way, you can recognize how it's very similar, but here's the numerical values, the end expiratory lung impedance values that you can multiply by the global reference. So I would do 655 times 0.23, and that would tell me how much functional residual capacity was recruited on a PEEP of 14. We're comparing still the 5 to 14. And again, we have that blue color-coded representation. Blue is a gain. So you have the numbers that right away you can tell numbers are positive. I'm gaining volume. You can see right away the trending of these impedance values. You can see the angles. Your eye catches that right away. And then you got the color coded one. And then you do a little bit of math and you got the tidal volumes. I did the math. So remember I said you just multiply, and it says 2.26 multiplied by tidal volume of global reference, which is a 655. So the 665, I multiply it by the impedance value. So I know globally, going from PEEP of 5 to 14, I've increased the functional residual capacity by 1,480. And if I multiply this 0.09 times the 655, like it tells me, I increased the dorsal region at the end of expiration now is splinted open with 60, pretty much 59 mLs more of distributed gas. We can do PEEP studies. The PEEP studies, very simple, going through it fast. The titration of 14, 12, 10, 8, and 6. Compliance loss on the high part. Orange indicates loss of compliance with higher pressure levels, higher PEEPs. And the white indicates a loss of compliance on the lower PEEPs or pressure part. So white is often indicative of a loss of compliance because of atelectasis, and the orange is a loss of compliance because of over distension. When we look here, we see that yes, we were able to recruit with 14, wonderful, but there is 21% over distension. So the PEEP of 14 is too high. Okay, we look at 12 as we go down. The compliance loss has been reduced, so the lung is becoming more compliant. At 10, we see here that the lung is again even less over distension. We're down to 10, but now we have to make a choice, because now we start seeing that we're going to have trouble with atelectasis. Considering the fact that this lung is predisposed to already closing, I would be a lot less worried about this 10% compliance loss here. It's a compliance loss. It could mean over distension. It doesn't necessarily mean barotrauma or anything like that. You still have to use this monitor and all the additional information that it's giving you to make a clinical judgment. So I would probably be keeping this around 9 or 10. Okay. Blast through this. Here's just a few more pictures. Here's your CT scan aeration, consolidation here, and you can see it's very accurate. And this is the X-ray. Here's the dynamic image of it. So we have a very, very accurate technology. Here's another example. Here's many other examples. This was when it was new to me and I was getting to trust it. All right. Here's some dynamic images. We're not going to go through this specific case study. There's many more. No. I just want to show you here's a nice one. This is a beautifully, like, you can't be more recruited. This was a COVID patient with normal aeration, however, severely hypoxic, so mostly microclot capillary damage. We had the patient on APRV, and you can see that this offered an extremely protective setting for the patient while we hope that the body could fight the virus. Here's aspiration during anesthetic induction. This was on AC-PC. We were unable to really normalize the distribution of ventilation at the bottom part. I was called to the recovery room. I said, well, you know what, can I put the PulmoVista and we can start seeing what's going? The patient was on 100%, satting like 88 or something. Tried, various recruitment maneuvers. Most of the time it would go to the ventral areas. You see here with the APRV, yeah, sure, maybe it's a little bit better, but see this white bar here? That's just telling me that a lot of the power that I'm pushing here with the vent to try and open this area is going to the ventral area, the more compliant areas, and that can put the good lung, the good area of the lung, at risk. So because APRV wasn't working its magic, I suggested that we prone the patient. This would put the patient's body weight on the ventral aspect of the lung, putting the body weight, splinting that compliant area, and encouraging, the opening of the dorsal region because there's no more weight on it. All right. I should take off all these arrows. So here's the picture, APRV prone patient here, put the belt, and this is the beautiful distribution after it. So we have ACPC, then we have APRV, didn't do the trick. And then we said, well, you know what, let's do APRV prone. But all of this was guided with the electrical impedance tomography.
When we were in the recovery room having trouble with the dorsal region, and watch this. Boom. I love my job. He's down to 35%. We got a P high of 18. And he's setting 94.
Yeah, the person was extubated the next day. So, and here's another example of dorsal collapses. This was another great case study. I'm not going to get into it. I have prior videos on this. Encourage you to maybe check some of my previous ones.
This is yesterday, the 12th.
So it's missing.
This is what I was talking about, the distended abdomen and the extremely dilated colon. So we see that this is a patient, one of the patients on a supine position, and you can see due to that increased pleural pressure and a complete elimination of aeration at the dorsal region. So we decided to flip the patient at the end of the shift. And here we are this morning, finally, with.
So these are really good results. They occur often. Like, that's a huge difference. Okay, pronum, APRVM, and normal distribution. And this is all within a 24-hour period that these lungs are changing. 24 hours. This is usually by the end of an 8-hour shift. We see here, these are additional. Remember I was saying you can do PEEP studies, but you can also, if you're using APRV, do P high trials, and it works just as well. A, B, C, and D, various P high levels. Again, trying to get below 30 because, that's protective. But we had, this patient was like this. That's how fluid positive this patient was, like the abdomen out to here, and it's like hard as rock. This patient was fluid overload. In these cases, limiting yourself to 30, it's not going to go well. But at the same time, you can't just blindly be guessing and stuff like that. So by having eyes inside the lung, by having regional compliance, distribution of ventilation, dynamic, trending, comparing, visually seeing things, you're able to safely, safely go, and also as an RT to protect yourself as well, to have all of the data. And the physicians are very, very happy that I'm able to use the PulmoVista. And we can, it just makes the job so much more fun. It really does. Like today, the one that I'm going to show you, I ended up not even taking a lunch because I was like, no, like forget about it. I was like having too much. I was too into what I was doing. So let's go see the case study. Now, you're going to notice one thing about this, probably get some criticism and flack. When we transition, this gentleman, he was on PC-PSV, PEEP of 10, pressure support or delta P of 15, so a PIP of 25, and a PEEP of 10, delta P of 5. He was on 50%, but he was here only for like encephalopathy, acute kidney injury. He had a little bit of fluid that needed to be removed, but he was just a very stock guy. So he was like probably 5'10" ish, but so he was like he was pretty short. Okay, so his tidal volumes on pressure support were 700, and when I transitioned, okay, to a APRV, since the peak inspiratory pressure was set at 25, I did the P high at 25. It started to recruit a little bit, and what I saw initially when I put the PulmoVista on was dorsal collapse. So the guy had a baby lung effect, and he was on 50%. And yeah, he was a little bit fluid positive, but he was intubated for non-rest reasons, and he's on 50%. So and like I said, he was not that tall, but he was a very, very high BMI. So he had a very large abdomen. So I was like 10 PEEP. I was like, nah, I bet you that's not enough. And the reason that I see APRV work sometimes, because sometimes they say, well, you can get the same thing if you just add a higher PEEP. That's not true. You're going to be spending a lot more time on APRV on the P high. So if you have pressure, let's say pressure control, peak pressure is 25 and 10, okay, you're going to get a mean pressure 16-ish, let's say. But when you put APRV 25, okay, and you extend the T high for a certain amount of time, you're going to end up getting 2, 3. This patient I put 5 seconds. So you go from a mean pressure of 16 to a mean pressure of it was a mean pressure of 22. So you're able to not increase your peak pressures, but you're able to have a better mean pressure. And there's a reason why conventional ventilation always, they have recruitment maneuvers, right? To do a 30 of pressure over 30 seconds, 40 over 40 seconds. There's a lot more aggressive ones where they put like a delta of 10 or 15, and they increase that to 25, the PEEP. I've seen some so recruitment maneuvers in and of themselves is a risky maneuver. But if you're allowing atelectotrauma, that's no better. So that's why we do recruitment maneuvers. But with APRV, you have the pressure and you can extend the time with the T high. So that's why sometimes APRV can work, because recruitment is pressure over time. It's not just about setting a PEEP. Oh, his PEEP's 12. Oh, dorsal collapse. Oh, just put the PEEP up to 18 to recruit. It doesn't mean that it'll recruit. It may not even need a higher pressure. It just may need that pressure being given constant for a certain longer period of time. So what happened here is when I transitioned to APRV, the tidal volumes during the passive release to ambient air were like a liter. They were large. When I did expiratory pause, the P low was measured as 15, so there wasn't a very large delta between your P high and your release to your P low. But yeah, okay, 1,000 is a lot. But if I tried to reduce the P high to 28 to 26, it would close up. So we're in this like little conundrum where, okay, it's not working in conventional. APRV is working with a P high of 30. The tidal volumes will alarm a lot of people because it says 1,100. Don't forget that this is not conventional where there's a PEEP of 15 and then I'm setting a liter and I'm pushing from a PEEP of 15 1 liter into the lung every time. No, this is a CPAP of 30 over 5 seconds, slowly recruiting, okay, alveoli and lung recruitment over time. And then after, we have a passive release to ambient air, and we stop that release when the peak expiratory flow during that release descends to 75%. Very brief release. And so anyways, this was during the recruitment phase. I'm going to let you know on the slope. So the lung itself has what they call a viscoelastic property. That means when you see your pressure, okay, drop down, okay, and then back up on a ventilator waveform, the lung is not doing 30, 15, 30, 30, 15, 30. No, when it goes from 30 to 15, okay, so the lungs here, the 15 goes down and the lung starts following slowly, and then it's already popping up. So it's a delay, right? What you see on the pressure waveform, is kind of like the tube and circuit, but the lung has a viscoelastic property and it follows slowly behind. So by putting your P low at 0, using the auto release, setting your expiratory termination at 75%, you will the ventilator itself will be constantly looking at the peak expiratory flow during the releases, multiplying by the 0.75. And the minute that flow descends to 75% of the peak, it's back up. So it's kind of like pressure support ventilation, where you're telling the ventilator when to stop blowing the pressure support. It's flow cycled, it's flow terminated. Well, that's an inspiration is flow cycled. Well, we're talking about the release. The expiration is flow cycled. The same concept. All right. Okay, let's check out this. Okay, before I go to the whole time that you guys will be seeing 1 liter, okay, during the recruitment and these releases of 1 liter, I am analyzing constantly the whole time I'm there, and I was doing a lot of export to a USB key. I wanted to pop up all of the customized analysis, the compliance results. I must have forgot it at work, but I was verifying, and I even brought my boss beside. I was like, check this out. Showed him everything, and I was like, but everyone's going to be freaking out about this leader. I said, I'm not worried about the leader. I said, we're not pushing the leader. I said, this leader is just, his lung is constantly, completely recruited, and it's just passively exhaling this amount. You can, if you have a slope, okay, I always put like a slope of 0.2 on it, which, because it goes down and instead with no slope, it bounces right back up. If you don't want to start playing with your 75% and stuff, you can get a little bit more exhalation, more volume with a little bit of a slope, because the the P low doesn't go up to the P high as steep, then that viscoelastic property allows a little bit more exhalation. It might drop your P low a little bit. So after what I did was, when you were looking at the liter tidal volume, I started playing off camera after I ended up bringing it to 0.1. We had volumes around 900. Anytime I tried going from 30 to 28, right there, I even kept it on for the next shift. I was like, look, I understand the liters. This is the best we have on conventional. We have a baby log. We recruited on APRV. We're stuck on 30 because anything else, it collapses. But that creates large tidal volumes. But the tidal volumes are these releases to ambient. We're not pushing it. So that's pretty much the pre-explanation, because I'm probably going to get flack. People are going to call me, shout out for the large tidal volumes. And I would also be, a little bit, I'm a lot more confident because I had all of the values. We were measuring it as we were going. You're less of a cowboy if you're just kind of guessing, 1 liter. Yeah, for sure the reaction was. But what I actually did was, there was he was on 50%, and by an hour or so, he was on 21%. He had an acidosis. Okay, the CO2 was high, and he was breathing around 25 with 700 tidal volume. I had him down to 10. He wasn't even breathing. He was just allowing himself to be on a T high of 5 seconds, releases. It made 10 releases. And so his lung now was moving half, because the rate was 22, 24. Now it's 10 movements. So we have 21% from 50. We have a normalized blood gas, and the chest is moving half of the time. So that was a satisfying case, It really makes the job fun. Okay, so 20 more minutes, Michelle, and I'll be upstairs with you. All right. I'm going to go to my channel. I just published PulmoVista 500 guided lung recruitment. There's 4 of them that watched it, and let's watch it. Okay, so we have a gentleman with a high BMI. He was intubated for encephalopathy, decreased level of consciousness. He's also in acute kidney failure and being dialyzed, a little bit fluid overloaded. We're taking 1 liter out at the moment. He is currently on PC-PSV, 50% FiO2, delta P of 15, and a backup rate of 20. So volumes, everything seems okay. When we go to the volumes are a little large. I'd have to do the 6 to 8 cc's per kilogram measurement. The guy wasn't measured yet, but we should see to do 6 to 8. But right away, when you put the electrical impedance tomography on, you notice right away the distribution of ventilation to the dorsal region is poor. It's on. Do you see that? See this circle? That circle is supposed to be here. All of this should have air. Okay, so this patient is not intubated for lung issues. So fix it. 4%, and even the mid-dorsal region as well. So this will become a reference for us. The reference stays there. He's quite large. He has a very, very large abdomen. So we're going to try APRV. Currently, we have a mean pressure of 16. We're at
25 of P high. So we're going to use that plateau to transition to APRV. 25 there. Expiratory termination, we use the auto release that will trap, we'll stop the descent to, we'll stop the descent from your P high to P low when the end expiratory termination is 75% of the peak expiratory flow, and it measures it for you. Okay, so let's actually accept all of these values, and we're going to see what happens when we transition. We'll start with 5 and we'll confirm.
All right. Give it a moment.
Give it a sec.
You're already seeing a little bit here. That's, I think I said it at 25.
Sweeten a little bit here. And then what I'm going to do is I'm going to adjust the P high. We're starting at 25. I'm not going below that because that's what the plateau was on the previous mode. So I'm going to do 25, 26, 27. I'm going to jump up right up to 30, and we're going to check if 30 is optimal. We have to open this up. Okay, so let's do that. I'm going to press pause and get right back at you very soon. Give me a sec, guys. All right, it's been another minute or two. Kept on titrating it right up to 30. So we're extending right now the
volumes there. So that's what I was saying. See the slope point 2. This here, just by bringing this down to 0, will reduce that tidal volume. So you can do subtle changes here, and 75 is usually the gold standard. And the 75, what it means is that the recruitment that is occurring with the pressure over time with your P high and your T high, the Dr. Nadir Habashi and his team in their labs have shown on pig models and stuff like that, that if you stop the release at 75% of the peak expiratory flow, it will maintain the recruitment that's occurred on the P high and T high levels. I have some videos of, when they put it under a microscope, the alveoli, and you see them, opening and closing and stuff like that. So that's why we follow basically Dr. Nadir Habashi's protocol called time-controlled adaptive ventilation. It's pretty much, there's been publications on it. My dream, I'm working with some people on possible publications, and we have too many projects that one person's doing, I'm helping, I'm doing one, they're helping. So we have to get the stuff done, but I would love to do a TCAV, randomized control trial with TCAV or something in our ICU, if that would be possible. Let me dream.
To 30. The releases, expiratory termination.
So you see it's at 0 here.
There. So it's 15. So the PI is 30 and it's dropping to 15 as a P low. So there's a delta of 15. Yes, understand that the volume here, this is all of the lung recruitment over 5 seconds. This is a passive release, okay? A passive release, and it's measuring that. So often when you're using APRV in the recruitment, a fully recruited lung released ambient pressure will give about 10 cc's per kilogram of ideal body weight. Obviously, studies have to check that out if, because we have the 6 to 8 is a protective lung, but with APRV, things are a bit different. But while we're doing this, we're guiding it with electrical impedance tomography. Right now, the pressures and the time pressure over time for recruitment with APRV during this phase, the most important is to open up everything. We want to get everything open. This guy had complete, dorsal atelectasis. So, the tidal volumes may have been smaller, but when you have only half a lung to deal with like 600 to 700, and now you might have a whole lung to deal with, higher volumes, then great. Now, obviously,
Yeah, it's like we had like a baby lung. We had 700, like we had a 700 tidal volume, and the guy only had half his lung. Now we pretty much opened up the lung completely, and now he has like 900. So yeah, 900 looks worse than 700, but yeah, at least the guy has like recovered 50% of his lung. I just wanted to show you guys this. I'm just going to stop sharing this for a second. I want to just present a slide from another PowerPoint I have, and here, share slideshow. Here, this is Upstate Medical University gross lung. So we have the traditional ARDS net method with 6 cc's per kilogram, and this patient, this is a pig lung. It had a delta P of 27. So low tidal volumes, very big pressure swings. This pig was 60 liters positive fluid. And we see the lung here at the end is shed. With the time-controlled adaptive ventilation, we have the tidal volume that is double. So we would say, wow, those volumes are too large. Very often with the time-controlled adaptive ventilation method, using the P low at 0, terminating the release at 75% of the peak expiratory flow, you are very often going to have lower delta Ps. And even though we have very large tidal volumes here, we see that the lung is pretty much pristine. Just want to show that. And I want to just come over and show you. Here is when we allow, this is inspiration. So you can see here the alveoli are nicely recruited. Are you guys going upstairs soon? Yeah. Okay. Because this is for work. 10% here. If I allow the release to 10% of peak expiratory flow, you see the alveoli here are de-recruited. The lung is very unstable. You're going to have atelectic trauma. 25%, still issues. 50%, better, but still issues. 75% seems like the Goldilocks, location where inspiration and expiration, there is very little difference, and as it should be. The typical lung only moves, is it 10%? It's such a small change between inspiration and expiration in the lungs, like the way we're breathing. Let me get out of here. You can see, these presentations that I've done for free on the channel. If you're interested, I'm going to stop sharing. Pretty much I started this because when I started using the PulmoVista 500 8 years ago, is it already that? I don't know, maybe 5 years ago. I'm not sure. But, I wanted I went on YouTube. I wanted to PulmoVista 500, and I wanted to see, and there was some stuff out there, and there was some doctors presenting, but not at the bedside case studies. You're there, filming the screen, you're watching it happen, you're looking at the vent screen and stuff like that. Yeah. So I said, well, you know what? it's unique that sometimes we use APRV and we use PulmoVista and we couple that together. That makes some pretty unique case studies and stuff like that. But no, I don't push APRV on everybody. To be honest, I'm comfortable using APRV pretty much as a primary vent mode, like Dr. Nadir Habashi in his ICU, but it's not a necessity. I'm just happy that our ICU is dynamic enough and open-minded enough and pro-RT enough to have allowed me to present all the information and listened and allow some of our patients to be on APRV when indicated. But no, there's no magic mode. It's just it's like this. I find some RTs have like this this wall to APRV, when in reality, if you actually the studies and you look through the studies, there's no studies that are saying it's dangerous. There's none. Well, there's none. There are criticisms of APRV. There are concerns of APRV. I remember a physician, sent me something, and it was like, I was like, oh, is it good? He's like, no, it's not good. And when I read it, it was an opinion piece. It wasn't a study. It was an opinion piece with concerns. And to be honest, there are reasonable concerns. But when you're there with the PulmoVista, getting all the measurements, seeing the dynamic changes, an opinion piece to me is an opinion. I'll leave it at that. All right, let's get back to the case study, see what happens. And we'll call it a night, another 15 minutes.
The high tidal volumes, this means that we should be weaning down the P high. I'm not going to leave it there, but we're still in a recruitment phase. And when we're in conventional and we're doing recruitment maneuvers, that is a dangerous part. Recruitment maneuvers, there's possibilities. So it's the same thing here with APRV. We're tolerating pressures. We're looking at opening up the lung. And then after, we will find the P high with the best compliance. From there, lung recruitment could occur, and that P high may not necessarily be required to be that high, and then we can wean down. And like usual, the P high, just like your pressure support or anything else, as the lung improves, it needs less pressure, the tidal volumes will go up. So that's how you know to wean your P high. So it's like any other mode of weaning. So over here, we're comparing the previous mode to APRV, and we see here that the end expiratory lung impedance percentage is a gain of 146%. So we have 1.5 more.
Yeah. So this is what I'm saying. That leader, okay. This ventilator, the result is telling me that when I went from the PC-PSV with the PEEP of 10, delta, 15, peak of 25, and I transitioned over here, the end expiratory lung impedance win, okay, the increased by 146%. All right, blue all around. If I would have, okay, let's just listen.
And expiratory lung volume, like we've recovered.
Yeah, so here. So the first one over here shows the distribution of ventilation compared from here to here. And then after, we can look at compliance win and compliance loss. So compliance win, where did we win the compliance? Well, wherever the blue is. Where's the blue? Everywhere. Where's the orange? nowhere, basically nowhere. This little blip there that might have just been an artifact. No, pretty much everywhere where the blue is distributed, we have an improvement. Oh, my granddaughter might have just woken up. We'll give her, well, my wife will be there, but she usually doesn't cry very long. My teenager came in with his friends, and probably they're being too loud. I'll let it play
Functional
out.
residual capacity, which is good. There's no losses really anywhere. So I'm going to create a report here. And then you can also just customize. Yeah, so obviously the compliance is way better in in APRV. So we're doing this, to pretty much justify step by step. We know compliance, we know distribution, and press pause so we get some more information for you. So over here, we're looking at the end of inspiration. So end of inspiration, you can see that everything was on the ventral, mid-ventral, very poor distribution dorsally, transitioned to APRV, a higher mean air pressure, allowing now more distribution to be occurring to the ventral region. This can, 5, 10, 15 minutes, an hour, 2 hours, we can look at this and we don't necessarily, have to touch anything, just see how it progresses. The tidal volumes though are quite high over here. So I want to kind of hurry up and get down the P high. I just want to look.
Yeah, so I'm thinking, okay, good. Let's see if we can still get this improved distribution of ventilation with 28 maybe or 26. The minute I went to 28, didn't go well.
To see how it's coming along. Not too bad. Right here. All right. So we're really opening up the lung well. Okay, so with the electrical impedance tomography.
All right, so over here, you see the A that's over here. That was the conventional mode. And then B was right away when we switched to APRV. And it's comparing and it's saying, yeah, you know what? When you were at A, you see all this white? That's compliance loss. The whole lung, okay, was not very well compliant. And this yellow part here means that there's cyclical opening and closing.
All right.
And then after we see here, as time goes by from B to C, we see that things are improving. And all the while that this is happening, those volumes are still 1 liter. Okay, so just keep that in mind.
We can look here, and when the patient was on conventional mode over here, the compliance was there was a 47% compliance loss. So there was all this white means that the compliance is really bad, and that the lung is at risk of atelectasis, lung collapse, and indeed that is what was occurring. So everything is making sense clinically. The results, just don't blindly believe them, but this is what we would expect. We see the yellow here, this yellow area. We don't want yellow. It shows cyclical opening and closing, lung instability, puts the lung at risk. We see here that now that we're at a P high of 30, we have a reduced cyclical opening and closing from 21% to down to 6. So everything is optimal here. This here is looking at lung compliance. If there was any over distension, it would start appearing in orange. There is 0 orange. In fact, all we have is a better lung recruitment. There's less, there's an improvement in compliance. There's no atelectasis occurring here. We have over here, we have, as these impedance values increase, means that we're increasing the functional residual capacity, the end expiratory lung volume. And I'm really concentrating on 3 and 4. I want to see a significant amount of increase here because that's where there was no ventilation. So we see that over time, 65 and 11, 74 and 14, we are.
Do you remember what I was saying at the start when I was kind of going through the basic introduction? See the impedance values. So the impedance values are all going up. Okay, there's recruitment globally, and we can tell that it's going up over these. And I can multiply the impedance values with the regional tidal volume if I wanted, and I'd get the actual volumes. For me, I'm just happy that we're recruiting compared to where we were. There's zero evidence of any over distension, and that's why I'm still allowing that 1 liter and stuff like that.
Again, we are recruiting. So we're recruiting on all levels, and it all depends, how fast you want to go. Do we just keep it at 30, aware of this tidal volume here that's really a release, right? It's not pushing 1 liter into the lung from a peak level. The patient is holding at 30 of pressure for 5 seconds, recruitment's occurring, and a passive release that is very brief, right? Stopping only, see, right here you can see. See, notice the release here. Look, it stops right there. It doesn't go down to 0. So we're not having these large delta P fluctuations.
It's basically purposely air trapping. We're purposely auto peeping. That's why we set the PLO at 0, and we create a very brief release. And that brief release, and just randomly based on the clinician, it's always based on the end expiratory, the peak expiratory flow. So as your compliance changes, you'll see that the curve of your end expiratory flow, it'll go like this, and then compliance gets worse, it goes like that. So as your compliance worsens, your T low will go down, and meaning you'll have a shorter and shorter T low, briefer and briefer T low. As your compliance improves, usually your T low increases. So once you set this auto release with it, and we've been using this for 4 years plus now, never had a pneumothorax. We have not had any complications on any of the patients that we've used APRV on. We have not popped a pneumo. That's again something that comes to mind. It's like we have a peak. We had a setting of PEEP of 10, delta P of 15, which makes a plateau / peak inspiratory pressure setting of 25, right? And it was pushing 25. Okay, so delta 15, peak pressure 25, had a rate of 22 to 24, about half the lung was missing. We transition to, let's say, a P high of 25. We stretch that P high 5 seconds, and we do a very brief release. And why would that cause a pneumothorax? I've seen people that were concerned. I'm like, but anyways.
Situations. What we're seeing probably is that with APRV, you're using pressure over time. You're getting a lot more recruitment, which is evident when you start using the PulmoVista a lot, and that these are just the volumes of a completely open lung being released passively to the ambient air for a very brief period of time. But more research has to be done on this. It's also nice to mention that we were on 50% here, maybe half an hour ago after transitioning to APRV, taking advantage of the ability to have pressure as well as time to recruit this patient relatively quickly. He shouldn't be on 50%. He's intubated for non-respiratory issues, but he is a heavy patient. And heavy patients are at risk of atelectatic trauma and things like that. So very satisfied with this one. Diagnostics. Okay, again over here, this was the issue.
And so that's what you're basically doing constantly. Okay, go back, to views, go back to diagnostics. Okay, it's been another like 5-10 minutes. Click, put up, my time, my points where my time are, and then analyze just to keep on trending, keep on making sure. Okay, anything changed, and again we're comparing A and B. Okay, so A is the conventional. Again, B was right when we started with APRV at 25, and then C and D is at 30. And we see down here, I can see there's no orange, there's no white. Like if there's white, there's just a speck here, and orange, there might be a little slash of it, barely.
When we're on PEEP of 10 on pressure support, well, it was PC-PSV, so it's kind of flow cycled ACPC. And then after here, we just started the APRV here. But already, look, it went down. There was a gain in 30% improvement in compliance. And then after we left it there, but just over time, look, we see now that the white is completely disappeared. There's a little hint of an orange at 6%. We're going to keep it there for a little bit longer. Then after, we can also test it this way. I didn't touch anything.
Like, I didn't make the dialysis machine ring. Again, here we have blue. Okay, blue is good. So this yellow cyclical opening and closing, okay, there's less and less as we go. We see compliance win 64%, 81%, 81%. We have end expiratory lung volume increase all through. We're up to 220% more lung volume at the end of expiration, right? That's a lot more. And don't forget, remember the one that was comparing ARD net, the lung that was all shredded? That's the whole point. It's like, atelectatic trauma, if you have a well recruited lung, think of it like a honeycomb, and each of the neighbors' adjacent walls are supporting each other. But the minute you start losing a bit, then you get those, those distortions. And over distension, we think at the end of inspiration, large tidal volume, something, but over distension can occur as well with a collapsed alveoli. So you have alveoli that are collapsed. The good alveoli that are beside those collapsed one, on expiration, actually it yanks them, it distorts them. You can actually have over distension of good alveoli that are adjacent to atelectatic alveoli.
And then over here, it's showing compliance win, compliance loss. We only have compliance wins, okay? 0 compliance loss. With that, so understand that this isn't just, blindly allowing this release. Everything is being evaluated. Everything is optimal here. Then after so that's recruitable. So you see compliance win percentage. We won 64, 81, 81%. And it's like well distributed everywhere. All that blue is a compliance win in all those areas, showing that the patient has an extremely high recruitability percentage, 162. And we're just keeping it. And look, it's recruiting 187, 220. And it's for that reason that I'm kind of hesitant to move that 30 yet. But that's based on.
And I tried to, and the minute I moved it, it closed. Like I forget, was it, I'm not sure if it was just 28 or 26. 26, right back to where we were with APRV. APRV tried to do a P high 20, gone, back to baby lung.
Your clinical decision. We could still do 28 and just recruit slower. So why don't we try that? Why don't we just go down right now to 28? Look at the release volumes. And what I'll probably do by the end of the shift is try and keep it maybe around 25, because that's what the plateau was prior. So we'll end up being with the same, PIP and the P high will be exactly set the same. And but we'll be spending a lot more time on the P high level, which will increase the mean pressure. The mean pressure initially was over here. It was 16. Now it's 24. We'll see once we get down to 25. I think it was 22. So we'll still get away with a better mean pressure, but the patient's on room air. So we went from 50% down to 21% quite rapidly, showing that there was significant amount of de-recruitment. Okay, it's maybe another hour about freeze framing. So yeah, very, very good result. We really started to see improvements over here compared to what we started out with. Now, what we're going to do now is starting to deal.
And this is 2 hours total, 8 hours, 16 hours tomorrow. I'm not working tomorrow, but the next day, like 8 hours is 8 to 16 hours. Like it's even more potentially, distributed evenly.
So post recruitment, we're going to start sneaking down the P high, and we're going to want to get this to about like 10 cc's per kilogram. 10 cc's, 10 mLs per kilogram of ideal body weight, and go there. Not going to go too fast, but slowly do that. Look here, see if we're losing any of the stuff we recruited. Go check the end expiratory lung volumes, the FRC. Keep on doing PEEP studies, looking at regional compliance, make sure there's no over distension. Okay, so now we just brought it down to 28. It's still a liter. Again, we're looking at the transition between the PEEP.
I'm like really trying to justify that 1 liter because I'm like, Jason, you're gonna put APRV, which might get criticized just because you're putting APRV out there, and on top of it, then you're putting a PLO at 0 and telling me that you're creating it. Well, people should know TCAP by now, but yeah, the 1 liter, I'm like, I'm gonna get destroyed in the comments. So that's why, look, the same thing again, compare here, and the whole time this 1 liter issue is going on, there is 0 atelectasis, there is 0 over distension, like literally 0, 0, 0, 0, 0, and I think this one has 7. And do you know why this one has 7? Because did you notice, look at the impedance values. What is the angle? It's the impedance values are going upwards. So from the very start, the whole time that we're there, it's still recruiting, guys. More and more and more and more and more and more and more. Even here, it was still recruiting. But then I started to want to return it, like, oh, can I get away with 28 or 26? And we see 28. We already see it's going downwards, and we see the first hint of over distension. Not over distension. We see the first hint of compliance loss, okay? But it's in orange, okay, indicating compliance lost. So anyways, just to say, this is the conundrum that we find ourselves in. I can't even go below 30.
10 when we were on pressure support with, you know, the tidal volumes were 10 to 8 cc's per kilogram, but half the lung was not making ventilation. So it's like, yeah, sure, the FiO2 is 50%, the tidal volumes are not too bad, and but we had no idea before putting this on that, you know, there was total de-recruitment.
Yeah, I didn't.
Here, what we're doing is we
That
look
bad.
the minute we transitioned from pressure support to APRV, you see all of a sudden zero atelectasis. As well, even with this 30, you see zero over distension. Zero over distension. Even if
You also don't see that yellow cyclical opening and closing, the RVD, the residual volume delay.
we're concerned about this, not forgetting that this is not pushing a P high of 15 and putting pushing a leader in. This is a CPAP that's at 28, showing that at 28 there is no over distension when that lung is held at 28, and there is a brief release from the P high to the P low, and this release here is extremely brief because we see at no time does it ever approach the flow of zero. And we know that there's not a huge negative, a huge delta P swing, which, you know, people could be concerned about. It's 14. So we have 28 and it goes down to 14. And this is a release of only about 1 second. Yeah. T-low is 1 second. And then we're back up. Now, what I'm going to be doing is I'm going to be bringing this down to 28, and then 26 and 24. And if I start seeing, loss or compliance issues that are getting worse, then I know that this guy actually really needs a higher P high.
He does.
Yeah, we're doing good. Optimal is at 30. I have been trying to bring it down to see how the lung reacts. Tidal volumes are still quite large. From PI of 30 down to PI of 26, we're really still hitting a leader. Again, like I said, I'm not worried about that. It just makes sense that pressure over time has fully recovered half of the lung that wasn't present, and I'm not worried about it. But, you know, I'm still
26, give it like a few minutes and it's not optimal. And so, oh, great, the volumes are a little lower. Yeah, you're gonna lose your lung. Don't worry, you'll get those normal tidal volumes of 700. Those 700 tidal volumes that he was taking on the conventional mode was when he had half a lung.
not doing it on purpose to try and keep that very high. The thing is that every time now that we start trying to lower the P high here so that people are more comfortable with the tidal volume there, now what you're seeing here is we're losing compliance and we're starting to have.
See, starting to spot there. And we went from 5%, now it's going to 8. And if we leave it there, I bet you it would trend, you know? And that's what, obviously, when you start losing, you're always going to start losing around the edges. You're not going to lose like a blotch in the middle often. It's always the edge of the aerated lung.
Areas that are getting over distension. So it's by dropping it that now the lung is over distending because things are starting to close up. So really this guy needs to pretty much stay around 30 to 28 P high for now.
30.
Okay, so, you know.
But it's really recovered nicely. Like look at down there. Don't forget the reference over here. You know, it's really good. The normal, remember, for the top here is 8 to 15, right? 35 to 40 for the mid-ventral and mid-dorsal. And so if you look at my reference, when I clicked it, it stays locked down here, the image, and the numerical values. So when we first started, when he was kind of Mr. Baby Lung over here, he had 11 distributed at the ventral He had 59 at the mid-ventral, and he had 25, okay, at 25 at the mid-dorsal, and he only had 5% distributed. It's supposed to be 8 to 15, okay? Now that we look, what's the difference? Well, what happened? We recruited at the mid-dorsal and the mid-ventral, just the right dorsal could be a little bit better, but I'm sure that will fix itself just another hour or so, or tomorrow you would put it on. It'd be a perfect blue marble. But yeah, everything's normal. Now it's like, it's okay. It's 7, 8 to 15 is the norm. Okay. And look, you notice this is a lot lower because now these numbers are bigger. It's exactly what we wanted. He was at 25. Now there's 34 distributed. There's only 5. Now we're between 8 and 15. We've normalized it.
Finally, the jury's out. This patient needs to stay, at least for now, at 30. Anytime I try and go 28 with the P high or anything, it closes up. So the other thing that we can do, if people are uncomfortable.
See here? Because it's the end of the shift. So I just, was like, okay with it, trying to get the tidal volume lower a bit with maybe a P high lower. That, as you can see, we're stuck at 30. So what I ended up doing was I decreased the slope. Again, the slope, it means that the ramp, it's just a little bit more steep and it goes up. That allows that viscoelastic property to not go down as much. So the slope, you can get a little bit more of a release, a little bit more of a volume. So I brought it to 0.10, and I got a blood gas, and the blood gas was acidotic. It had been acidotic for like I don't know, because I didn't look at the previous days. I looked at the one we had, and the CO2 was 50. It was a combined, because he was on dialysis, so he had a metabolic acidosis, and he had respiratory. I was like, oh, he has respiratory acidosis. That's why I was like, no. Big belly man, no issues with his lung, on 50%. And the other thing is that he was breathing at 24. So we have a guy that went now from 50% oxygen requirement down to room air. Okay. We have a guy who was completely de-recruited to being pretty darn well recruited. And his breathing was 24. And now he's allowing the vent to breathe for him. And he's breathing at 10. And with that 10, he has now a normal blood gas. Of course, now he has, way more diffusion capacity because he's pretty much recovered half of his lung. So this is kind of where I left it, which is, in my opinion, acceptable. Around 750 is 10 cc's. So it's a little more than 10 cc's. I also increased the 75%, which I rarely do. I increased it to 80 because the blood gas was normal. So I was like, hey, you know what? We can always bring it down to 20 to 75. So I left there with reasonable volumes for APRV, and
with the higher tidal volumes, and the blood gas is normal. What you can do, you will adjust a little bit the tidal volumes with your slope. So because there's a slope here, okay, and the descent is a little slower to go up, the viscoelastic property of the lung allows it to go down a little more, just a fraction of a second, and it can play with your tidal volumes. So if you have normal blood gases, then just make the slope ramp up quicker. And that usually, if you're uncomfortable with that, it'll lower the tidal volume. So that way you can stay with the 30 and you're getting closer to volumes that are not going to be of concern.
yeah, I mean, I probably actually could have put him at 0, and that probably would have brought him pretty close to the 10 cc's. And then it's like win-win. Everything's good.
So perfect. All right. I also,
So I just posted this case study that I did today, but I felt like I needed to do a live stream to watch it and explain it because, yeah, you know, you're throwing your work out there, and this, I was like, I gotta do a live stream and kind of explain why this is that high, and you know,
since the blood gas was
what do you think? Am I bad? Is this incompetence? What are your opinions? Do you agree, or are you like, no, this is dangerous? What is this guy doing?
normal, I said, you know what, I'm going to even terminate the expiration at 75 instead of 80, at 80 instead of 75. Let's see what the new P low is.
15.8.
15.8. All right.
All right, so 15.8. So it's even lower. The delta P is below 15.
Great. That's the end of it, guys.
That's the end of it, guys. All right, so I'm going to try and be more active on this channel, doing more case studies. This is the end of the video. Thanks for watching, guys. Please share, subscribe, and I'll see you next time.